This is inspired by some eye signs that I've seen in myasthenia gravis in the clinic, and some that I've missed as well recently. And I started this with sort of an interest into why these particular muscles were involved. And I learned that the extraocular muscles, firstly, have less mature synaptic folding and a lower density of acetylcholine receptors. So that's one reason why these particular muscles are susceptible. A second reason is that they obviously have an extremely high motor neuron stimulation rate. So that's the second reason. And the third reason is that complement regulation at the postsynaptic junction of extraocular muscles is less so than in other muscles, and that makes them potentially at greater risk of complement-mediated damage. So that's why the extraocular muscles in particular can be involved, and whether the levator muscles sort of follow these rules is less well known. So I've skipped past the basics of ptosis and fatigability and moved on to something slightly more interesting. So that's Cogan's lid twitch. It was initially described in 1965, and it's demonstrated in this diagram here. So you ask the patient to gaze downwards for 10 to 15 seconds, resting the levator muscles. They return to the primary gaze, and you will see the upper lid overshoot and then fall again back to the baseline. That's known as Cogan's twitch. Although this can be demonstrated just by the simple down gaze and then return to primary gaze, it can also be seen in horizontal pursuit movements, and then it's described as lid hopping. And now, is that video working?
Yep, it is.
Perfect. So you can see whenever this lady moves to the left and the right, the eyelids are flickering up and then falling back down again, and that's known as the lid hopping sign. So a couple of studies have looked to try and identify and determine how sensitive and how specific the Cogan's twitch sign is for a diagnosis of myasthenia. The two larger studies both had significant problems, and that's, I think, reflected in their results. So between the two of them, they decided that sensitivity ranged between 50 and 75% and specificity between 25 and 99%. So not really particularly helpful. And I think the important take-home message from this is that Cogan's twitch is not specific for myasthenia, and it can be seen in other causes of ptosis and other extraocular muscle problems, including Miller-Fisher syndrome, myopathies, dorsal midbrain lesions, etc. So moving on to the next sign we're going to talk about is Herring's law and the Carson sign. So Herring's law states that there's equal innervation to ocular muscles, and that's relevant to the levators also. So there's bilateral and equal neuronal stimulation to both levators. In an asymmetrical ptosis, therefore, when the more ptotic lid is passively elevated, the contralateral lid will drop. And the reason for this is because less firing is required to elevate the ptotic lid that's being lifted. There's a decreased firing on the opposite side as well, and that leads to this contralateral ptosis. And you can see that hopefully this video will work with this lady. You can see her left eye's with ptosis, and when that's elevated, the right eye also drops. And that's known as the Carson sign. Again, this is not specific for myasthenia, and it can be seen in other causes of unilateral ptosis. However, it's clinically important because whenever patients come to clinic with unilateral ptosis and they're considering getting lid lift surgery, this may actually cause a ptosis in the contralateral eye, as demonstrated in the pictures below, where the gentleman had ptosis affecting the left eye, had corrective surgery on the left, and developed a right-sided ptosis instead. And the final eye sign that I'm going to talk about for myasthenia is one that I've been called out with, which is pseudo-INO and other causes of other ophthalmoparesis. And I think the important thing that I realised from this is that myasthenia can really mimic almost any painless pupil-sparing ophthalmoplegia. You can see in these 4 photographs, in A, the gentleman is trying to look up, and in B, he's trying to look to the left. Whereas the C and D are after treatment with pyridostigmine. But there are numerous case reports of myasthenia mimicking INO, mimicking progressive external ophthalmoplegia, and also of other conditions, therefore mimicking myasthenia as well. The important point here, therefore, is how to try and differentiate between myasthenia and other causes of ophthalmophoresis. And the key differentiators are that within the limited range of movements, the saccadic velocity should be normal in causes of ophthalmoplegia other than myasthenia. So there should not be any slowing or fatigability with repetitive movements. The pupils obviously should not be involved in myasthenia. And if the patient reports symptomatically any degree of variability, consider myasthenia and send the antibodies. So to summarise, there are no eye signs that are specific to aid in the diagnosis of myasthenia gravis, and myasthenia can mimic other causes of ophthalmoplegia. The importance of recognising these signs is more in monitoring treatment response, and it can have clinical relevance for treatment options, such as for when patients are considering surgical intervention. And that's it.